just want to make sure I have this for my, okay. So ground rules, the meetings start on time. Vegas rules, what's said in here stays in here. Yeah, and you know that this is just really an open space because I realize that everyone, depending on like what role you are in, you get to, you know, look at health disparities. Some people don't. The main people I interact with in my day-to-day, at least with Community Care for Health Justice, are students in public health. And surprisingly, they don't actually get to really apply a lot of the things that they're studying. And so they've, you know, I've had people who have joined Community Care for Health Justice basically because they feel like they're able to actually look at these issues in an applicable way. So it's really a space for that. It's really a space for people to discuss things that aren't always a daily part of like their work or their school. And then let's see. You already got your drink, so that's good. Already done with that. All right. So the Q&A speed round, I do have more Q&A questions. And most of these do cover, I would say, the beginning of the book. So we should be good. All right, so I might need to move this a little bit. Move us down here. All right, so according to Paul Starr, what is the original sin in American health policy?
Yeah,
I have all the answers, so I will read them.
Oh, yeah, go for it.
Okay, so let me click it here. So Paul Starr calls, let me move this down a little, calls Congress's decision to link Medicaid to welfare and Medicare to Social Security the original sin, because it really just separated the two types of health insurance or health care coverage, by one being focused on your level of income, focused on, you know, really on social welfare and poverty, and then Medicare was tied to really the opposite. It's kind of it's more based on, like, I would say, a level of merit versus a need. It's kind of like scholarships, to be honest. Like how, like, I don't know, I understand the purpose of the merit scholarship because like I actually got a merit scholarship for school, but classifying that as separate from need is kind of like a little bit questionable.
Yeah, because I'm based in London, I was trying to understand all these terms and I thought that she'd explain it, what the key difference was, but I had to Google it, and it was difficult because I feel as though they can be used quite interchangeably throughout as well.
Mm-hmm.
And there were quite a few things actually that confused me, and I highlighted one of the lines that she said, if you're confused, it's okay. Because in America, there is no basic level of healthcare to all citizens. And that's kind of the default. That's what the benchmark should be. So if you're confused, don't worry. Thank God.
Right. Yeah. It's like, it was amazing having to learn this in school, because every time you sit in class, it's like, this doesn't make any sense. Like, it's so different if I was in another country and I was learning about the healthcare system and it's like, oh, that makes sense. That makes sense. This person gets care. But when you're in a public health school or a healthcare program in the US, it's like you're learning this stuff, but it doesn't actually really work, to be honest. And it's not helpful for a lot of people. Yeah. So, okay. This one is kind of, I don't know. Okay. So why did white people in Illinois receive transplants at higher rates than blacks or black people?
So I did highlight that Robert and, where is this? The long wait Robert and other blackface when they seek kidney transplant is almost twice as long.
Mm-hmm.
But I didn't actually write what it's all the issues that you mentioned, you know, the bias, the mistrust, the things that you mentioned in your first slide.
Yep. Really long answer for what you just said. It's the bias. So Lawndale, let me see, where I where I was working was, where was that? It's not Lawndale. Well, it's another heavily Black area in Chicago. So Lawndale's further to the west. Where I was is further to the east. But yeah, it's just, I mean, you would be amazed. Like, there's no grocery store. Like, when these communities get a grocery store, it's a big celebration. And it's just, and then you go up to the north side. Like, I live technically in downtown, but I live on the south part of the downtown area. But the north side is like, so luxurious, and it's just so stark. It's definitely one of the most segregated cities in the US. So
Interesting.
healthcare is
Yeah.
segregated.
One of my friends mentioned something. A professor said that in two towns in London, he cycles between for work, and there's only an hour distance, but the level or the life expectancy between the two towns varies by 20 years.
Mm-hmm.
And that's just in one cycling route, an hour. So the fact that you're saying you have these disparities,
Yep.
but on a crazy level, what's that, an average of 13.9 months?
Yep.
Wow.
And the life expectancy that you just mentioned is similar, and it's actually within miles, sometimes within, I would say more miles. Yeah. So like on the north side, someone can live, a white person can live like a white person can live like 80 years. And then on the south side of Chicago, someone can live like 69, 68 years. But the distance is not that far. It's not like these communities are segregated, but they aren't very distant. You can get from one to another within like 15 minutes, maybe 30 if you take the bus. So yep, it's and I think that this kidney conversation is really interesting because it's multifold. So there's a lot of, again, that lack of trust, and people don't want to even sign up to be a kidney donor. But race is actually really important, like that they're saying the genetic factors to get matched for people. But it's a combination. Alrighty. And then I only had maybe 3 speed round questions. Okay. So what reforms to the American healthcare system does the author recommend? And these can be kind of broad.
Yeah, well, I'm good because I've only read the first 100. It's odd pages, and she hasn't touched upon the reforms yet. Just the but one of the things I did find interesting was the medically necessary parts that she mentioned. And I'm guessing in the latter part of the book she'll talk about that and how it needs to be broader. So, to include transportation or the examples of nappies that they gave throughout as well.
Mhm.
I'm sure she'd mention that.
Yep, exactly. Access. She suggests that there needs to, of course, be access, just like in other countries. We need access. That's a big part of it. Disentangling Medicaid from social welfare because that really stigmatizes it. And then improving those connections, like you were saying, to transportation, to housing, and connecting those to healthcare. I would be curious to hear, like within your country or in other countries that are those things like housing and transportation connected to healthcare? Because they are not so much here.
Yeah, so we have the NHS, the National Health Service, so our healthcare is free. So I'm sure there's going to be the same sort of things, the mistrust or
Mm-hmm.
symptoms not being taken or patients not being taken as seriously, the paranoia that she talks about, all those things would still have an impact. In terms of housing, yeah, I don't know. I guess people of color tend to live in more overcrowded housing,
Mm-hmm.
more generations. So a bit like the family that she's following around in this book, 4 generations. Um, transportation, not so much, but they are closing more hospitals and more wards down. So
Mm-hmm.
you're having to travel further to, I don't know, the maternity wards in another town. Although it's a neighbouring town, it's still another town. So we have those, but not as the disparity that she talks about is on another level, I think.
Wow. Yeah. So it sounds like there's a lot that we need to do.
Yeah.
So that is all the questions for the speed round. Time to get to the main questions, which I really do appreciate this book. Like, I mean, I like books from all different types of authors. Like when I read this, and I've read other books focused on Chicago, and they're actually not all written by Black authors, but um, I think sometimes it's even really great to have a perspective that isn't as connected sometimes, because so like this woman, she's writing about this family, but I mean, of course, if someone in their family were to write this story, it would be slightly different. But I kind of appreciate an outside look at what was going on, because I do think it was quite honest. But I think that that's pretty important. So I do really appreciate this book.
And her writing style was very accessible.
Yeah, and very true, very true. And that's not always the case either. Um, so yeah, I know we talked a bit about already the
I
Medicaid.
would prefer you get, because yeah, there's still so much confusion around the two.
There's 10 questions, so we can always skip around. So this one, we can skip this one. Oh, did you want me to like explain them out
So,
a little bit?
yeah, so you mentioned briefly why that it's problematic, but what are the key sort of differences?
Sure. Yeah. So I'm going to use my notes here so I can double check for you. So Medicaid officially is the state and federal health care program for the poor in the U.S. It has never really lived up to its promise to eliminate the tiered system in healthcare, but it was created in 1964 with the Civil Rights Act in the US, in the civil rights movement, because the people recognized, or the president at that time recognized, that it's not enough to just declare and give people equal rights. You need equal rights to certain types of programs. And that's also when I think Head Start was started for education and school lunch programs. So there's a lot of things going on in the 60s, but they were both started in the 60s. And they differ because, again, Medicaid is for the poor. Medicaid's income restrictions are very limited. So basically, Medicaid only covers half of people who are poor, because what she's talking about a lot in the novel is that it's a game almost. It's like if you want to get your healthcare coverage, some people have to stop working, because even though they're making minimum wage in America, they still are making too much money to get free healthcare or covered healthcare. So it's like it becomes this really messed up game of like, okay, I'm going to stop working so I can get my healthcare coverage, or I'll get my healthcare coverage. Or no, sorry. Or I won't get my healthcare coverage and I'll keep working, but I'll be in pain. And it's a really hard novel in that way, because that's literally how I understood it as. It's like this kind of, issue. And it's just not like that in other places where you're really self-sacrificing. And then Medicare, let's see what they say officially for here. Medicare is an entitlement program, so that's different, even how it has entitlement in there, that covers most Americans who are older than 65 and certain disabled people. So with Medicare, it's focused on you meeting a certain age requirement, and then you get this care. But that's really in quotes, because there are still a lot of people of color who will make that age requirement, and they don't even get it. And I don't actually know why that is. I think it's because there's a lot of stipulations still. Like if they're still needing Medicaid, they might not get Medicare, even though they are 65. So there's a lot of issues with it, even though this has been around. And for some reason, this is saying that it was around in the 80s, but let me double check for you. Medicaid. I'm pretty sure that was the 60s. Yeah. I think maybe it was like standardized in the 80s.
So it pays to be poor, doesn't it?
Yeah, that's essentially what it is. It's like if you are poor, then you can receive this sort of service, but there's still so many gaps, and like you can't always get coverage of specialists. So if you have, I think someone in here needed their foot amputated, or they needed something amputated. So like you can't always get access to specialists with Medicaid. Like eye care, there's certain things that aren't even covered that are necessary for youth and children. And also those programs are being cut very often. So like with our current administration, and I'm not getting, it's so frustrating. But with the current administration, like whenever it cycles from, Republican to Democrat, you'll see the different shifts in funding. And unfortunately, like funding will be cut from Medicaid, it will be cut from SNAP, which is for supplemental nutrition for mainly for women and children. What else? They'll also cut like WIC programming and WIC funding, which is for women, infants, and children. And so I don't know why they cut this funding when it switches, and it's like that's why I have such a struggle with I guess with public health and healthcare, because it is so political. Yet so many people in health are like, no, it's not. It's like, but it is, because someone can literally come in and be the president or the administration and just literally make it really hard for people to live. And then there's really nothing you can do because they're, the legal authority.
Yeah, and it always seems to have a disproportionate impact on those that are most vulnerable, for mums, especially those with children under the age of 5.
Yep.
Always targets them. So, okay. No, that makes way more sense now. Appreciate that.
Yeah. And I think everyone in the family pretty much uses well, I guess it's whoever is 65 and up would use Medicare, and then everyone else would use Medicaid, because the whole family is technically underserved in this story. Or I guess this might be a true story. I think it's a true story.
Yeah, no, it is. And yeah, I think the way that she wrote it was so beautiful, because it was about one family and how healthcare affects each one of them differently based on their socioeconomic background. And all the things about the missed appointments, because one appointment's on a Monday and one's on a Thursday, and it costs $70. It made it more real, I guess. It put a face to the statistics. So it was a different writing style, but I guess because I'm quite new to learning about these things, it was nice for her to use a real example. Just made it more real, I guess.
Yeah, and I applaud her for it, and I think more authors can really try with this writing style that really just reflects on the people who are involved. It's so easy to say, people of color as a blanket statement, but it's real people, it's real lives that who don't have access to just basic things, and she really tells that story very well. Alrighty, so this is a loaded question, but why didn't Robert get treatment for his kidney condition before it became life-threatening?
So I've got the quote: he was not poor parent enough, he wasn't old enough or sick enough. And there was this constant theme of he had to prove, or people have to prove that they're poor and that they're deserving of support. And what's this? It doesn't. Yeah, I'm trying to read my own notes now. So there was no sort of prevention throughout. It was in terms of a customer journey or a patient's journey. If you intervene at the earliest possible point, you get the best possible outcome. For Robert and for Mrs. Jackson, it seems as though they're intervening way too late in the journey. And when they talk about Mrs. Jackson having her foot amputated, for someone who's, or was it foot, or was it no, I think it was, if you've had a leg amputated, you've got a 50% chance of the other one being amputated. So surely that should be a red flag, right, for healthcare professionals, that, okay, we need to ensure we do everything possible. But yeah, it's just crazy that people have to be sick enough or get sick, yes, to get sick enough to then see someone or to then be admitted into hospital. Yeah, so those were the sorry, I've got highlights on my book, but I haven't wrote notes for them yet.
No, that's exactly it. That there was not, you know, there's like a limiting of, well, first of all, there isn't good access to care. So he was working low-paying short-term jobs that didn't have health insurance. They also, a lot of people who are struggling financially, they would put off healthcare because they have to pay for other things, you know, in that meantime, you know, food for the kids, school, other transportation. And I believe also, let me double check on okay, this is the 80s and the 90s. So that's another part of it. Like, even now, healthcare has issues, but in that time, I can only imagine. Cause yeah. And then let's see what else they wrote. Yeah, basically people who can't afford food and shelter, barely, why would they feel the need to spend on healthcare? Especially because you might not even know how long you're gonna live. Like, I work with youth in the city, and there's this idea of like, well, I'm just gonna do what I want to do now because I don't know when my last day will be. They're constantly surrounded by violence in their communities, and it's constantly on their minds. So this mindset of just delaying care actually it doesn't make like the medical sense, but it makes a lot of sense from just my interactions with people, and even some of my own family. I would say it's more about when we get to care for elders. So I have, you know, one person in my family who definitely has true signs of some sort of dementia, but he doesn't want his care. Like, he's just like, no, I don't want it. And there's also so many issues with that. Like, and then I have another grandmother who she grew up in the Dust Bowl in Oklahoma in I guess that would be the 50s or the 40s. So she has a great distrust of anything medical. Like, she just doesn't trust it at all. And so these sorts of trust issues are not going to help, almost regardless of how much, like, I don't want to say regardless of how much money you have, but if you don't feel trustworthy of the healthcare system, it's not going to really matter if you can afford to go, because you're not going to even, you know, trust it. So it's like, there's so many levels.
Yeah, and on that note, she mentioned something about poor women dying in large numbers from cervical cancer, which
Mm-hmm.
is very preventable, I'm
Mm-hmm.
guessing. And all it is a simple smear test. So people are coming too late because of all of these other factors.
Mm-hmm.
Yeah.
Yeah, and with this cervical cancer, that's another thing that's tied to culture and into sometimes a fear of talking about certain things, because cervical cancer, even though I don't think it's 100% tied to like reproductive, I guess, activities, if you want to say, but there is an idea that it is. And so it's like, I remember growing up, my own mom, she didn't want me to get that whole, I think it's like the HPV test, because that was really big when I was growing up. It was like the HPV test. But she didn't want me to get it because she had an association of, that's for girls who are having sex already. And like, you're 11, you don't need you don't need that test. And so, but yeah, there's like that association as well. And so I know, and I don't want to speak for all Black families, but I do know for my own family that that's a real kind of reason to push away from that. So then me, as my own age now, I take responsibility for my own reproductive health. And I hope to, you know, I think it will just change over time.
Yeah, and yeah, the point you just mentioned about the cultural factors as well. One of my friends she's from an Indian background, and she developed breast cancer, that for the Indian community or her family, they used to call it the C word. And there's plenty of other words that start with C that you'd think like a swear word or a curse word. And she said people in Indian communities don't like talking about cancer because when it comes to getting their daughters married, no one wants to marry into a family where there's it may be in their genetics, and it may be, oh, your offspring will, if you do marry into this. So yeah, all of these cultural reasons why people don't talk about it, or don't go to the doctor, or don't want to speak about these things. So yeah, I guess that's another reason, all the cultural factors, because none of these things happen in a vacuum. Nobody's life is no one's life is completely silo where it's not affected by anything else. There's social factors, historical factors, environmental factors. So the healthcare industry, see the fact that I even use the word industry, that it's a money-making business. They need to have a more holistic approach.
Yeah, definitely. All righty. How is Robert's dialysis paid for? And I'm gonna click this because let's see. Oh, okay, yeah. So it's one of the two things we discussed earlier.
So it would be, is it Medicaid? Or is he over 65? Oh, no, it's the aid, isn't it?
It looks like it is. Oh, so this was a trick question because it looks like, I'm reading the answer here. So Medicare pays for the dialysis units of a fixed fee for each dialysis session. But Medicare, let me see. But Medicaid would pick up the patients who don't qualify for Medicare. So he could have it paid for both, from both sides. And also it's because people with what he's suffering from, like the diabetes or certain health conditions, they will be covered by Medicare if they are severely disabling for people. And so it kind of, that's why these two distinctions are also really confusing, because for some people, they will have certain things covered by Medicaid and Medicare, and then others will only have it by Medicaid or Medicare. It's really a mixed up system. That's why at the end she kind of really sounds like she's saying you need to just delete both of the systems and then rebuild.
Start again.
Yep. Let's see. What are DRGs and how do they affect the care given to Miss Jackson? And I'm finding the answer. Okay, I found it. I admit these questions are a lot more specific, but that's because it depends on where I get them from. Like sometimes they're on Quizlet, sometimes I make them up.
Okay. Yeah, no, I guess when I go back and write my notes, I'll be able to make way more sense of some of these things.
Yeah. So DRGs are diagnosis-related groups, and they were created for Medicare in 1983. And so in an attempt to control costs, Medicare began to pay hospitals predetermined rates for patients, depending on their diagnoses. So that's really interesting, because basically, they don't want really sick patients in the hospital because that just grows the cost up. So by putting people in these diagnosis-related groups, it just kind of controls the cost, but it doesn't really separate or tailor their care. So it's not really tailored for the care. It sounds like for Miss Jackson, let's see. The The change eliminated the 100-day annual limit. Oh, okay. So then I guess there was an annual 100-day limit on home health visits. And
Yes.
so with the change to the diagnosis related groups, that was eliminated. So it lessened the amount of visits that she was able to obtain, which is hard, especially if she, I think she lives in Lawndale. And hospital wise in Chicago, there's only really one major trauma center or a main hospital on the South Side, and that's University of Chicago. Which is actually like a really large international school, which I didn't know. Like they have students from like all over the world. But that's like the one school or one hospital that is on the South Side, which is predominantly Black. And then on the North Side, you have Northwestern. And then on the East Side, you have UIC. And then you also have Sinai. But out of all these hospitals, there's only one. And they talk about Sinai in this book because I've been there. I did a whole institute where I learned more about these whole topics. And they're one of the few hospitals in this area that still really caters primarily to very, very low income patients. They don't turn anyone away. And so that's something that most hospitals across the country, they still do that. Like it'll turn people away if they can't cover something, but Sinai doesn't do that. And so they have a hard time, and she explains it in this book, but it's still current because I've spoken with people. They have a hard time breaking even as a hospital because they're not incurring all this money. But they still continue to do their work. So they're really needed in this community.
Yeah. But I did have something. What was this? Oh yeah. So since hospitals receive a set amount for patients, regardless of the cost of care, they have an incentive to discharge patients as soon as possible.
And that is and I don't know how much you know about like the maternal mortality issue, but oftentimes what's happening is that, or with mental health true also, like women are being discharged really early even if they're having issues, and a lot of times they are Black women. I know with mental health, I heard a story about a Black man who was discharged too soon, and then he ended up committing suicide. And so it's showing you how this this profit model can be very dangerous for a lot of people, and it is dangerous for a lot of people.
And one of the lines that stuck with me is that it doesn't pay to sit and deal with people's emotional problems.
Mm-hmm.
That was deep.
Yeah.
So yeah, they're sending people out or home too early. They get sicker, and it causes more problems further down the line. Madness. Even here, after you give birth, they used to keep you in the wards for two days. Or my mum, I think when she had me, or my older brother, they kept her in there for 4 or 5 days. And it was, for family as well, it was great because you knew they were being taken care of. And even when someone wanted to come home, it's like, no, you're in the safest hands possible. Just stay there, just relax, and then you can slowly learn about motherhood if it's your first one, or your children. You've got enough time to give to the baby and to the other children. But now, like, if you give birth in the morning, they're trying to discharge you by the end of the day, and trying to reduce the number of people that stay overnight, which then results in more healthcare issues, accidents at home. So yeah, this bit really got me. You're prioritizing profit over people. So yeah, I highlighted quite a bit of this.
And like the way I see it on a positive note is that since we keep talking about how there are all these other factors like transportation, there's the cultural stigma, there's lack of trust, there's economic instability. Healthcare is one of the few things within health outcomes that we can fix, and we see it does work in other places. So the fact that we as the United States can't fix it is really shameful in my opinion, especially because other countries have done it and they do it successfully.
Definitely.
Yep.
And yeah, it had a disproportionate impact as well on what we were talking about earlier, more vulnerable families, where they're having to care for someone who's ill. They may then have to take time off work, which will have a knock-on effect there. So slowly, like one domino knocks over all of the other ones.
Yep, exactly.
The vulnerable families.
Yep. And if you're the primary caregiver, so if you're the mom, or the dad, I know in my family, my mom's the primary caregiver. So then that in that way, if that person is out, what does that do for the rest of the family?
Yeah.
So it's all tied. All right, this question was really interesting, so I wanted to add it. And I didn't know what this was until I read more about it. So the question is, what is demarketing? How is it used? And what are its consequences?
So I haven't come across that term yet. I'm guessing it's in the latter part of the book.
I think you're right. Let me find the answer. Let me see. Let's see here. Okay, found it. So demarketing was the unconventional tactic, and then they put in capital letters, denied by Mount Sinai in the 1980s when it made a formal reaffirmation to serve the disadvantaged, including those on public aid and the uninsured. So demarketing includes intentionally creating long lines in the emergency room, eliminating primary care clinics for the poor, and shunting non-paying patients to waiting areas with few seats, poor lighting, few signs, and no food or drink. The point of demarketing was to discourage uninsured patients from using hospital services, allowing the hospital to generate revenue off of the remaining private paying patients. But Sinai rejected this strategy.
Okay.
Yeah, I'd
That's
never heard of that before.
Yes, yeah. Try and make the environment as least welcoming as possible to try and deter people from staying.
Yeah, it's not. I mean, yeah, I can see people doing that. And I don't think I've seen it now, but I can see that. I mean, of course, the 80s weren't that far off from the civil rights movement. So I could see it happening in the 80s, and hopefully not now, but you never know.
I've heard it happen in other areas. So to stop homeless people sleeping on benches, they'll deliberately put a barrier in the middle of the bench so they can't lie down. I've heard things like that to try and deter people, or sleeping in car park staircases. They'll spray it down with water so that it's wet so people can't sleep there. But I've never heard it being used or I've never heard any examples from hospitals.
I know. Like, I've really done some side research on hospitals. I started getting into it when I was in school because I was like, I wanted to be very ethical and honest about health and the barriers for people, for patients, and for their families. So I looked at the civil rights and how it was connected to hospitals, and how hospitals initially were only reimbursed by the government when they served people on public aid, so people who got Medicaid. But then at one point it was like they didn't have to share because the law was overchanged, and so they didn't have to have as many people. So basically the percentage of people they had to serve on Medicaid, on the healthcare for poor individuals, that percentage decreased. And so then they could then get all their patients that were privately paying. So they had private insurance. And so, but that was something that came up in the 60s, and then it got kind of overturned, probably because of the differences in administration. Like, when it's amazing when the administration changes, like, you see the broad you see the broad changes that happen, but there's also a lot of things that do change that you have to just really look at and study and watch the news. And yeah, and so I think that's just one of those things. So now a lot of hospitals barely will cover people on Medicaid and mainly Medicare, because Medicare is at this point mainly for like older white individuals. I mean, I don't know. I have to talk to my grandparents, to be honest, and I'd love to hear more about like what Medicare they're receiving, because they're 65 and up. But as far as I know, and the statistics that I've seen from Kaiser Family Foundation, it is primarily for white people. Yep.
Okay. I had a question, but now it's gone. You hold on.
Mm-hmm.
Oh yeah. So you said that they've rejected this demarketing technique.
Only Sinai, yeah, only Sinai. It looks like Sinai and then a dozen clinics. So yeah, Mount Sinai, it was really, and it's on the west side of Chicago, but it's still one of the few hospitals that is like, no, we are not built off a profit structure. We care for everyone regardless of what they're suffering from. Their trauma center is constantly, like, they constantly see people with gunshot wounds, because unfortunately that's what happens in parts of Chicago. But a lot of other hospitals do not do that. Like, they might see 0.5% of patients who are on Medicaid. My own, like, I have a family member who, is in healthcare, and I don't believe that, he takes people on Medicaid for what he does. But, so, I mean, of course there's different reasonings and whatnot, and if you're a specialty versus general practice, but yeah, it's really definitely changed who has access to things, because I'm sure that there was better access to care at one point in the 60s and the 70s, but then somehow with all these different, unfortunately there was a lot of drug issues happening in communities, not to the fault of the communities, but there were those issues, and then civil rights was still continuing. But nowadays, it's just, there's so many loopholes that a lot of healthcare systems can take, and then they prioritize their privately insured patients.
Wow, that's madness.
Mm-hmm.
So when did they reject this, or when was it introduced?
Looks like the closest, it says the mid 1980s.
Oh, okay.
Yeah.
Oh no, because I thought this was more of a recent thing, which would have been.
Oh no, because Sinai's been doing this. So they've been around, and I can look up when they were formed. But yeah, they just have an amazing history as a hospital, and it was great to go there. And we didn't only learn from the people in the hospital. We actually then took tours around the city, led by community. What's the word? Community social workers, community health workers. So people who work directly in the community and promote health services that they can provide. So not directly medical, but other health promotion services. So Sinai Hospital was founded in and they also have Schwab, which is a rehabilitation center, and that's really not heard of to have. About. It's probably a history section in here. Oh, here we go. Sinai in 1919, and it was also founded by Eastern European Jewish immigrants. And so the way that Chicago is also set up is that, especially on the west side, it was primarily at one time a Jewish community. And so it was founded by a Jewish community, and they were serving and they were working with, Latino immigrants and Black people. And then there was a large shift in like where people moved, but they still continue to serve this community. And that's just really unheard of as any hospital, like I would like to say in the country. Then again, I don't know all the different hospitals across the country, but I do think the fact that they continue to serve this community while still incurring really heavy financial cost is pretty unheard of, especially in healthcare. So it's great that she focused it around Sinai, and the rehabilitation center that they have as well, because again, that's a whole system of specialists that, you know, if you have an amputation, you have diabetes, you're not going to get that care, just period, or it will be too expensive. So the fact that they have this other rehabilitation center is huge. So yeah, and I guess that obviously the consequences are the consequences of this system of demarketing. I just think it's just not really cool.
Yeah.
um,
By putting it, yeah. What are the consequences? People who may actually need medical care are just, yeah, or they may just say, oh, Chelsea, don't bother going to queue up for the doctor's appointment. It's going to take 45 minutes. And at the end of it, you might not even get an appointment. Just those things. It's,
yeah.
Yeah, I don't know how else to explain it. Yeah, I guess it's just people won't
Like
go.
community, yeah, it's like, it sounds like it has a community influence. If you know that you're, if mom knows that the treatment is bad at this place, then she's not going to take her daughter there, her friends aren't going to go there, and then it keeps that cycle of delaying care until the last minute going. And you know,
So our GP just up the road, the doctors, you have to ring at 8:30. They open their lines. They don't open until 9 o'clock. But if you're not on the phone at 8:15 and first in the queue, or if you don't start queuing up at 7:50, and then you know, if it's at 8:10 and you're in the queue, or you're considering going the queue, you forget it. I don't need a same day appointment. I'll try again on Wednesday. So
yeah.
just because of the lack of access to it, you push it, or yeah, I guess you're not getting care as quick as you need it because of all these inconveniences.
Yep, absolutely. That's 100% the reason. All right. What kinds of medical care aren't paid for by Medicare? If Medicare won't pay for Miss Jackson's care, where can she get coverage?
So is this what we mentioned earlier about the nappies and the transportation not being deemed as medically necessary?
Yep, definitely. 100%. And even something that I'm seeing more of, which is good, is childcare services within hospitals. But that should be that should just be a given. I think there should be a staff member who can sit with the kids. Like, I know I volunteered once as a child life specialist volunteer, but my role wasn't, I mean, to an extent we were watching the children, and we got certified to watch the children, but they were with their parents. So it's not like, but I think there should be someone who is maybe a child life development specialist who can even talk to the children about what they're going through. Like, you know, if you're going and visiting the hospital every day, that's gonna weigh on you as a child. I know people say that, you know, you only have certain memories from a certain age, but I just have a hard time believing that. I think that those effects do affect you longer than people give it credit for. Like, so if you have a sibling, if you're 8 years old and you have to go to the hospital to visit your sibling who has cancer, you're going to remember that. And is there someone in the hospital who can really talk to that child when their mom or their dad or their guardian is taking care of that child? The most stressful thing I saw when I was volunteering was that some of the parents felt like they had to be in multiple places at once, and they shouldn't have to feel that way. So there should be someone who's like in the hospital, like an actual staff member that maybe is not medical, but they have this literal, like, you know, child development, psychology, psychiatry training. Actually, psychiatry is medicine, but they have that training to take care of the children in the hospital. And so part of childcare, you know, it's not covered. There were probably some other things in here. Like there's a lot of things that were in here that help soothe someone when they're going through something. So like with diabetes, I mean, in this book, there was no place that they were talking about nutrition. And people have diabetes, so it's like that's never covered. There's ways. Blue Cross Blue Shield, which is a really large health insurance provider in the U.S., and they are really great about access to the things that help someone be healthy. So like in Chicago, they have really great fairs that happen honestly like multiple times a week, that will provide free nutritious food, free fitness classes, um, free health literacy classes. So, certain insurers are doing that in the US, but a lot are not. A lot are focused primarily on, just that cost retention. And another large area we're having issues in is prescription medical costs. They're still extremely too high. But there are some insurance that are doing things like that. But that's one thing it's never covered. Like how is someone going to have diabetes and you can't find a way to help with their nutrition?
Just what you were saying about having some form of carer at the hospital, is the impact that would have on the child's mental health, or even on the nutrition. Like if they're in a hospital, what type of food are they getting, or are they getting their meals at a late, or do they have to wait until they go home to get fed? Like all of those other things, which is why again we need to think of healthcare holistically, and all the cool things that you've just mentioned that go on already, these free classes, free fitness classes, how to use computers, how to access the internet. All these things are connected. It feels really, I get really, really frustrated when reading these kind of books. I'm like, what idiots do? It's basic. It's common sense, isn't it?
Yeah, definitely. It's just, I think we need to have different people also in the room. I think a lot of the people in the business suite of healthcare, they have this business background, and that's fine. We need a business background, but we also need people who understand sociology and who understand psychology and, Africana studies and these things that really matter for making healthcare holistic, as you said, and culturally sensitive and culturally competent. And so we need to start valuing other industries and other professions. And it sounds silly, but we also really need to, and this is another question coming up, but we need to value mental health care providers. We don't value them equally to other types of medical providers. And it starts from the mind. It starts from, being mentally ready and sound.
But even with the example of Mrs. Jackson, if she's not getting, or if she's having to pay for nappies, or let's say she runs out, or they can't afford it, for argument's sake, that means she can no longer go out, because mentally it's like, okay, I can't, I'm, what if I have an accident? And just from a little thing like nappies, it has so many, it has so many different impacts on her well-being, on her mental health, on just so many things. Like she may not be able to see, her friends or family, losing that social structure around her. So yeah, there's so much more than just nappies.
Yeah, definitely. I didn't even think about that, the social element of all of this as well. Like yeah, definitely. Like there's that whole, and she talks about it later when she gets at like the depression, but also just like the social element of, are you comfortable going out, knowing that you have a certain health condition, like on a social, are you comfortable sharing about it? Are you comfortable with other people knowing about it? Yeah. So if Medicare won't pay for her care work and she get coverage, let me double check this answer. Let's see here. I skip it. Oh, wait, what's the question? Okay. Hmm. I did. Okay, sorry. Let's see here. So she can get care from medicine, elderly people, do not have to worry about. So, okay. So the closest that Miss Jackson came to a Medigap insurer in the months she qualified was Medicaid. So sometimes if you can't qualify for Medicare, you can qualify for Medicaid, which is the care for poor individuals. But as this is describing, it's like, it's really a hit or miss. So, depending on honestly her other sources of income or her family sources of income, one month she might be able to get that care and another month she might not. So it's very uncertain. Mm-hmm. All right.
She was lucky in that she had Jackie with her,
Mm-hmm.
pushing for her to be seen or exaggerating illnesses. So there was the example she gave that of Miss Jackson's toe, and when she rang up the what's your equivalent, the fire brigade or the whoever it would have been, they said we don't come out just for a toe and just because she's experiencing pain. And then she had to say other things or get creative and say, oh, she's had a fall and her stomach is hurting. So the lengths that she has to go through even to access the care that Mrs. Jackson needs, crazy. And then it makes you think that the people, those individuals that don't have a Jackie by their side and don't have a Jackie who know the system, and how to, I'll use the word exploit the system. What happens to those?
Yeah, definitely. Definitely. Yeah, I think the advocacy, the patient advocacy, that's what we call it in.
That's the word I was looking for. Yeah.
Well, we have in the US, we have patient advocacy groups, and they're kind of another part of the healthcare equation that isn't always utilized, because there are times where you go into the hospital by yourself. There's times where someone who is Spanish speaking or their another language is their dominant language, they don't have a translator. And there's a lot of conversations about that because yeah, so a lot of hospital systems don't always have the translators, but they are supposed to actually through, it's actually like a legal thing, through I think Title 5. There's like some law in place that says that they are, if you are serving a certain population, you are required to then have medical translators, because then it gets into the ethics and it gets into HIPAA. And I don't actually know if you have a same, is HIPAA universal like across the world, or do you have an equivalent to a sort of privacy law in healthcare in your country?
Yes, yeah. So we have GDPR,
Oh,
which I can't for the life of me remember what it stands for now. Data protection, and
yeah.
yeah, we have the equivalent, I guess. Yeah.
Okay. Very interesting. Yeah. But it's just a lot of different things. All right. Another interesting
Ooh,
question.
this is the bit I was just on actually.
Yes. What is Medicaid spend down? And this was another thing I had to learn about, I believe. I think I learned about this in school. Oh, yep. This is basically the things that I was talking about earlier about how, in order to get Medicaid coverage, people, so specifically Miss Jackie had to spend down or not spend, or yeah, she couldn't bring in more than $292 a month in order to qualify for Social Security, and for it to qualify for Medicaid. So like she couldn't. she had to kind of almost limit what she was bringing in order to get her care, which goes into that whole ethics piece of, well, that makes no sense that you have to limit your income in order to get care. And that really doesn't make sense. Like if someone else reads this book and like if I were to give this book to like someone, it's just loaded with a lot of atrocities.
I think I'm that person because I have no knowledge at all on US healthcare. When I was reading some of these things,
Yeah.
how does that make sense? But I guess it's similar. We have stupid things here as well. Like you you if you're working more than 16 hours a week, you're not eligible to certain state benefits.
Mm-hmm.
But the living wage hasn't increased.
Mm-hmm.
So it makes sense for you not
Okay.
to work. Yeah, not to work and stay on benefits because then, yeah, it pays to be out of work.
Mm-hmm. See, right now, yeah, and like right now, I don't know how other countries are doing it, but with this administration, they've been sending out, I forgot what they're called. I think they're just called some sort of like benefit, basically like benefit checks for people who are out of work. So like for me, I know I received one, but I actually didn't have a financial loss of that, at least of that magnitude, but I did receive that. And that check was actually smaller than my tax refund. And, and I thought that that was really stand out to me because it was like, so this economic payment check that's supposed to help me support myself was less than my tax refund. Um, so I think that I like the idea of this whole economic benefit because I'd be curious to see if this would have been a thing in past administrations. But at the same time, there are a lot of people who actually have like quit their jobs because they're actually getting more money through these economic payouts. And I think that's also interesting, but that also just shows you like how some of the jobs are not really sustainable for a lot of people if you're getting more money from this payment versus your own, career.
Mm-hmm.
Let's see what else she wrote in here. The Department of Public Aid has has strict income limits as well as cumbersome rules that made it a headache for people who are chronically ill. It's pretty, and it was Jackie's responsibility to gather medical bills and receipts month by month and take them to the local public aid office in order that she get this money. So there's also that whole like administration of this, organizing your bills and all these sorts of credentials so that way you can get your aid back. And I wonder if there's even, I know there's in the US we have, actually I don't think, well, they don't give it as much funding, but we had patient navigators who help people navigate the Affordable Care Act under the last administration. And those navigators, they don't have as much money in this administration. They've been severely cut down. So people were having issues getting enrolled in the ACA. But yeah, like all these administration aspects to it, that's probably hard to navigate in addition to, actually trying to get the money that you need.
And the administration side of things that you mentioned is again having to prove that you're poor enough,
Mm-hmm.
that you're eligible for this.
Mm-hmm.
And I think somewhere in the book she makes the point that when Mrs. Jackson didn't need, or while she was working, she was eligible to everything. But once she stopped working and once she's ill and she needs the support, it's not there, or there's 1,000,001 barriers in the way.
Yep, absolutely. It's a really sad example of where we really still are, 25, almost 30 years later. And I think, as I always say, I think since healthcare is one of those things that we can change, we can't change all of our environments. Like, the environments in Chicago, they'll need a lot of investment in work more so than let's try to make healthcare better. It sounds really complicated, but it actually really just takes political investment. And we have a lot of money in this. I mean, it's $1 billion industry. So it really just takes political investment and will. And if we can get there, then, you know, we can do it. But it's easier to change than changing environments. And we need to change those environments as well. But we have to also just start from what we can change. At least in my understanding. Yeah.
Yeah, no. I like that.
Alrighty, question 8. Let's see here. If Medicare serves everyone over 65, why do minorities and the poor seem to get worse care? If Medicare serves, why do minorities and poor seem to get worse care? Let me find this question in here. It looks Okay, so the answer that they have for this one is that the lack of continuity between private offices and outpatient clinics is the reason for the worst care. So the lack of continuity. And she writes, and right here, it's a complicated question because that lack of continuity, in my humble opinion, is not because of Miss Jackie or the family, like, because she doesn't control that continuity. The continuity needs to be created by the billion-dollar healthcare industry and making sure that people can continue their care more easily. But that's what they're saying for that. I think it is a complicated question because it's everything we already talked about as far as the trust and you know, being comfortable in your healthcare and all that.
If someone isn't invited to the party, you don't ask them, hey, why weren't you invited? No, you go to the host and you ask them, right? In the same way, you can't force people of color to then come up with the solutions. You're $1 billion industry. Surely you are the host of the party, so you should be doing all you can to be as inclusive as possible.
Yep, definitely. Definitely. It looks, okay, and there's a summary here. Differences in the ability to receive transportation or lack of awareness of transportation options. So that's a good point too, because like I said earlier, there are some insurers that will help with transportation, but if you don't have internet, if you don't have an awareness of knowing about those services, then you won't use them. And so in that way, it's not even always that someone doesn't have access. It's like, do they have access to the information about this program? Lack of continuity. They wrote, minorities and poor don't primarily go to private doctors' offices, but to outpatient clinics where they receive sporadic care by different people each time. Oh, that's a great point. Yeah. Like the care where, and I don't know if you're familiar with kind of the outpatient versus inpatient, how significant that is here, but primarily Black people, especially I'll speak mainly for Chicago because I have the data for that. But primarily Black and brown people, but I will say primarily Black, utilize the emergency room because, again, it's like you put off care until the very last minute when you can actually get that care. And when they get that care, it's sporadic, as they said, and by different people. So if you might not even know who that person was that treated you, to be 100% honest, and then whoever signs that document might not be that doctor. It might be a nurse practitioner. It might be a PA now, because everything is really segmented. So yeah, that's a great point that this person said, like, you might see different people as well. You might see that one doctor and never see them again. And then how do you continue your care?
It's almost as though we all need a mini care manager, right?
Yeah. Yeah, I think there needs to be healthcare has done a great job at being more administrative. Like I think that there are new roles because when I was in school, the roles that they introduced us, like because part of it's like you're learning, but they also want you to think about like careers. And so some of the job roles that they talked about were very management oriented. It was like you as a health communications person, you would help a doctor with their health education materials, or you help with their management side of what they do. And so they have those roles, but I think they need more of those roles, to be honest. I think we need more people in those roles, and we need more people who are culturally competent, because that still is an issue. And that goes across race, it goes across gender as well. Like, I mean, I know for me at this point in time, I would just purely prefer to see a woman physician and PA and all of those different things. And I don't know if that's always the case, even in 2020. So it crosses a lot of lines as well. Religion, you know.
So what if your female doctor was only available on a Wednesday morning?
Yep, exactly.
Yeah. There was a really nice example that she gave. I'm trying to find it now. Oh yeah, Dr. Jones told of one woman who was suffering a severe case of hives caused by allergic reaction to her cat, yet repeatedly refused to get rid of the animal. I really kind of got angry, Dr. Jones remembers, and then she told me that if she got rid of the cat, there was nothing to protect her kids against rats. Another woman brought her 2-year-old to the clinic with frostbite, so Dr. Jones dispatched his nurse practitioner to visit her home a block away from Jackie's. The nurse discovered icicles in the woman's apartment because the landlord had stopped providing heat. The stories goes on, most involving landlords who cannot afford to keep up their buildings and tenants who cannot afford to leave them. So all of these things, like, yeah, if you just treat it's the example, or what's the beautiful quote, like, there comes a point when you stop pulling bodies out of the river and you look at what's putting them in there in the first place. That one I highlighted. I thought, wow, that's such a powerful example of why it's so important to look beyond the issue. It's a gaping wound, and sometimes we're guilty of just putting a plaster on it.
Yeah, definitely. And it's like, again, it's like this industry has so much money. And so I mean, I think we're getting closer. There are really, great standout groups that are trying to do more of this work. But it still will take a culture shift. It will take a shift from, like I think I could think of like 2 main groups that do this work. And fun fact, they have a lot of diverse leadership.
Yeah.
Like it's just what it is. Like I think for one of the main groups, the main CEO, he actually passed away, but his successor is also a person of color. And the thing is, like, I don't like to have to think like, oh, it will take a person of color to make this great shift, but that's literally what it is. Like, it's kind of sad that we have to think that way, because I would like to think that everyone can come and try and value diversity and these important considerations, but at this point we're just not there. And so we will need to continue to advocate and put diverse leadership up in healthcare. But yeah, that's the main groups that are doing that work. They're led by people of color. So all right. And question 9, making good time. Oh, great. Okay, so this is the mental health question. According to the book and author, how is Medicare biased towards inpatient psychological care? So Medicare is the one that is for 65 and up. And so given the demographics that I shared about how it is primarily serving older white individuals, and of course mental health is already so stigmatized. But let me look at the answer for this one. Oh, great, I found it. Okay. So after Miss Jackson lost her leg, she became greatly depressed. In addition, she never attended a support group because they were held in the mornings when she was at all able. The physical therapist preferred to see her early because she was stronger then. So she couldn't go to the mental health support group because she was at her physical therapy group because it was only offered in the mornings. The infrequency of Miss Jackson's sessions with Walsh is particularly a reflection of the low priority rehab facilities in general put on psychological therapy. At Schwab, which is at Sinai, they only have they only have very limited number of psychologists there. Inpatient psychology may get relatively little attention, but outpatient gets even less because they get less funding, they get less commercial insurers, and there's just minimal coverage for outpatient mental health services. So public insurers are even less generous. So basically, they just don't have enough supports, it sounds like, in terms of outpatient mental health services. And then you have to consider the providers who will provide that service. So then that's a whole nother, there's another book that I don't think we looked at that book yet. But The Death Gap by David Hansel, he really gets to the point of how different individual providers will kind of separate out their care, and that's a hard conversation as well, because if you're a doctor and you go to school for all these years and then you need to now make your money, it's so hard to then be like, well, no, you should serve here, you should not serve there. But that's another part of it for mental health care providers, because there's already few of them. So then how many of them are going to say, oh, I'm going to care for people that need public services?
Yeah.
Yep.
And I guess there also needs to be standardization, right? Because I don't know too much about the insurance companies and the big ones, but if everyone's got a different criteria and if everyone values psychological health in different ways to each other, and I guess it just depends. It's a bit of a lottery, really, isn't it?
Yeah.
You could have very good mental health and not need a insurance company at the time, but who knows, you could deteriorate very quickly, and you're kind of stuck, aren't you?
Yeah. And I really appreciated how they addressed this mental health aspect within this book and within the context of Miss Jackie, because you don't always see and you don't always hear about the mental health effects of a medical issue. So she lost her leg, and then now she was suffering from depression. But then how many hospital systems are then gonna, give you pamphlets for support groups? So it sounds like she knew about the support groups, but she didn't have access to them because they were at the same time as something else. But how can hospital systems and healthcare systems do better at promoting those mental health services? Because there is a level of depression and anxiety that can occur after any health concern.
Yeah, or even the fact that she wouldn't tell Jackie to do certain things because she didn't want to be more of a burden on her than she was. So yeah, there's quite a lot. No, even if it wasn't a case of depression or anxiety, just the fact she doesn't want to go outside because she doesn't want to be a burden. That's a huge thing, right? Yeah, and the other thing I was going to ask, I haven't read this part yet, I guess. I know that in or medical health professions or Black people are given higher doses of antipsychotic medication, and their symptoms or they're classed to be more, patients, especially men, are classed as being more aggressive, and the sort of connotations that, or the prejudice and the bias that there is there. Does she touch upon that later on?
You know, I don't think she does, but the last book that we talked about does touch upon that. The Medical Apartheid. She talks a lot about the mental health diagnoses and how schizophrenia was really initially it was initially tied to slavery, and when slaves would escape or a black person, you know, acted out, it was like they're schizophrenic. Like it was initially like a racial mental disease. So Harriet Washington talks more about that element. Um, but yeah, I didn't see too much of it in this book. But that is a really great, you know, conversation of the cultural stigma surrounding mental health.
Yeah. Okay. Cool.
Yep. And final, oh no, there's another question after this, but okay, so I think we already touched upon this a little bit, but why do emergency rooms get used for routine care for I guess, you know, the Black community, for poor individuals, for maybe even also immigrant communities. I know this book is primarily focused on this Black family, but actually that's a whole nother thing. I need to find another book that focuses on immigrant communities, but from healthcare, because I actually was looking for it and I did not find any books on that. And maybe I need to put out a call on social media for that, because I couldn't find any that focus primarily on healthcare, because I know in Chicago specifically, there's a huge barrier of getting healthcare. And there's like literally one or two clinics in Chicago that the Latino community will go to because of fear of really deportation, fear of all these different elements, and also just not having people who can like speak the language. But it's a real concern. So I was just a tangent, but I do want to find another book that focuses on that.
That's good. So why are they used? Just because they come too late in their journey, for all the reasons that we discussed earlier.
Yep, definitely. Let's see what they also said. Let's see.
And I guess it's also what you mentioned earlier about the other problems going on. If you don't have a roof over, or if you're worried about keeping the roof over your head or the food on the table, they're very imminent and they need to be done now, and I need to deal with this problem. Yeah, you know, my leg is hurting, but I can deal with that. Or I've got headaches, I can deal with that. And you just kind of get used to the pain, or you get used to the idea of, or the someday island. Someday I will go and visit the doctors. But so many things are coming up. I need to take time off work and all of those, things that would be discussed, I guess.
Yeah, absolutely. All those things were previously said. Let's see. Yeah, they might be in advanced stages of their treatment or their illness. Let's see. There's also a fear that they can't afford private care or private appointments. So they just people naturally might go to the emergency room. And I always say these sorts of conversations, I do see this from such a different lens, because I have so many people in my family who are in healthcare, from nurses to doctors, and yeah, like they would probably agree that it's just not a really good system as it is right now.
Yeah, definitely.
But, and then I have some bonus questions on here. So as we move through COVID-19, in Illinois specifically is actually in what we call phase 4 in across the United States. So not to my happiness. I'd much rather kind of wait a little bit of things out. But there's things that are opening up. There's like movie theaters, gyms. I'm like, oh no, that's a little bit too much for me. But anyway, so as we move through COVID and these disparities, what barriers to care do you see occurring for Black and Brown communities? And then do you think our healthcare system will become more flexible or adaptive to patients' needs during the pandemic or due to the pandemic?
So I think we briefly touched on this last month, actually, that Black and brown people, we're more likely to live in overcrowding housing. We're more likely to have jobs on the front line, whether that's in healthcare, or I know for the NHS in England, we are disproportionately represented in healthcare. So that's anything through from cleaners to doctors. And yeah, we've got more ongoing health issues. So I guess those are the reasons that we are disproportionately impacted. But what's the other bit? What barriers to care do you see? Specific to COVID? Yeah, I guess it's we're more at risk, and companies or workplaces need to do more risk assessments to make sure that their staff from what's it called, that are more high risk, that there are things in place, or whether it's a case of them working from home 3 months longer than everyone else, just workarounds, I guess.
Yeah.
Barriers, I don't know, what other, nothing's coming to mind.
No, that sounds about right, because I think we do need to consider the demographics of this industry, and then consider how to meet those needs. That's important.
Yeah. So, and do you think our healthcare will become more flexible? I'd like to say yeah. Well, do you think they will become? Do I think they should? Yes. Do I think they will? No. I want to be optimistic, but yeah, I'm not sure about that.
So I guess I know with our healthcare system, I don't know. The only thing I've seen is the telehealth and making remote healthcare more accessible, but it hasn't actually it's made it accessible for people who have internet and for people who have computers and technology. So there's still a lot of people in urban settings and rural settings that aren't getting that. They haven't done anything for the connectivity. They've only done something for the actual, here, we have a doctor who will meet you on your computer, but the connectivity part hasn't really been met. So that's a glaring gap I see.
And you'd also need a translator on at the same time.
Yep.
So you're very much dependent on the translator's availability. Yep. And if the translator, I don't know, is ill one day and has to cancel their appointments, hey ho, Chelsea, your appointment's now cancelled as well.
Yeah, definitely. That's a great point. Yep. So, any additional questions or any additional thoughts or anything that stood out to you in the book?
Yeah, I think the only point I haven't mentioned from the notes that I did write is the rationing medication part. What's her name? Jackie didn't give Mrs. Jackson medicine for 3 days, or that it was the blood pressure pills, and the doctor said, oh, her blood pressure's quite good, whatever you're doing, keep doing it. So yeah, that bit where we just sort of automatically assign pills, treatment, without looking, or I think it's quite an easy thing to, no, I don't mean it's an easy thing to do. It's just just looking at, all right, this person has high blood pressure. This is what I need to do to help them. I need to give them the medication. It's not a case of, okay, you need to improve your lifestyle. You need to eat better things during the course. It's not looking at all of those things. And the fact that sometimes the patient's family know best, or the patient knows best. So we're very quick to assume, you know, oh, you're being paranoid, but when they are doing the right thing, we sort of ignore it.
Yeah, the rationing medicine is all too real, especially for people with diabetes. As far as like insulin, a lot of individuals, it's really common, unfortunately, of rationing their insulin. Not everyone even has access to all the different types of diabetes help or diabetes treatment plans. So from like the pump to the pill to the patch and all these different things, like it's just not easily accessible for everyone. So there are a lot of people who have to ration their insulin. And I mean, I wasn't too surprised to see that that's something that she was doing. But with like or like rationing her treatment, but like it's just, even I guess I get to the point where I'm like, well, if people in healthcare are hearing that this is what people are going through, then how long will it take for them to then adjust, adjust things to make it easier for people?
Yeah. Well, I know some GPs have been, or during COVID, like they rang up my mum and said, don't worry, we're going to be delivering your medication to you. So some of them have been offering that delivery service. So
Great.
those are the sorts of things that they can do to support people during COVID who are deemed high risk or deemed as highly vulnerable, doing what they can really. We're doing what they can, or doing the best they can with what they've got, regardless of a person's socioeconomic background.
Definitely. Mm-hmm. Yeah, let me see if there were any other questions that were interesting on here. Well, I already explained how Mount Sinai, which is constantly featured in the book, like why they're in the shape that they're in, because they're treating, low income patients, and they're doing it out of the goodness of their heart, and they're not looking at profits. But that does make it difficult for them to survive as a hospital. So yeah, I think that was, let me see, responsible for, I think it would be also interesting to hear more about the, like how healthcare impacts children and young people. I'd love to see a novel about that, and their parents, but really from actually a young person's perspective. I think that would be an interesting novel to read.
You're coming up. I like this new segment you're doing in the book clubs, where you suggest a book that should be written.
Yeah.
Last book we had, last month it was all about COVID and the disproportionate impact, and now this time it's about young people's perspectives. I like that though. Yeah, that's more of an anthropology sort of study, right, or something for their field.
Yeah, definitely.
Yeah, and how different cultures view healthcare or illnesses, because that's definitely got to play a factor in all of this, right?
Definitely, yes, 100%.
Oh, cool. Well, it's almost 11 p.m. here, and I've been sitting down for an hour and a half, so I feel my back. I need to walk around, do some more steps. Thank you so much again for organising this. I'm going to finish, hopefully, reading the book over the next couple of days. But this has been so super helpful to get one-on-one with you. Yay!
Yeah, I know. I appreciated speaking with you as usual.
What's the book for next?
Yeah. For sure. Okay,
Oh,
so
there we go.
next month, the book is Supersizing Urban America: How Inner Cities Got Fast Food with Government Help by Chin Zhao. And so this book is really interesting because, and again, another book that I've read, but he's looking, and it also again is about Chicago. So it's looking at how mainly McDonald's, but some other fast food chains have used the system of franchisement to really kind of infiltrate Black communities, because they're giving this business opportunity to Black communities, but at the same time, it's not a healthy option for the most part.
Yeah, detrimental to health. Ah, okay. That sounds like a brilliant book because, yeah, we've had quite a few conversations recently about poorer areas having more takeaways, having more fast food restaurants, having more gambling shops, and how those things really aren't helping. And if anything, they're creating a bigger gap, I guess, between the richer and the poorer people in the same town, and the disparity just grows. There's so many different factors. But okay, brilliant. I'll jot that down. You've put them all up on Eventbrite already, haven't you?
Yes.
Yeah, okay, awesome. Supersizing. Wonderful. Well, thank you so much for spending your Sunday evening with me.
Thank you so
Enjoy the
much.
rest of your Sunday and catch up with you next month.
Absolutely. I appreciate you being here, and have a great rest of your night.
Yeah, have a good one. Bye.
Bye bye.